Bienvenidos todos, sean a esta masterclass del Instituto Nacional de Cancerología en la serie de tópicos en ginecología oncológica. El día de hoy tenemos a la doctora Christina Fotopoulou. Ella es profesora del Imperial College London Healthcare Trust, es subdirectora del Hospital Universitario Charité de Berlín y es coordinadora principal del Centro Europeo de Competencia para el Cáncer de Ovario. La doctora Fotopoulou el día de hoy nos hablará por qué no ha sido exitoso el tamizaje en cáncer del ovario. Why a screening program in ovarian cancer has not been successful. Este es un tema de gran importancia para todos los gineconcólogos, para todos los ginecobstetras que ven pacientes y que en algunas ocasiones no sabemos cómo proceder con estas pacientes, si debemos o no debemos hacer estudios de forma rutinaria con el afán de identificar las neoplasias epiteliales del ovario en forma temprana. Y como ustedes ya saben, esta neoplasia se diagnostica en etapas avanzadas en la mayoría de los casos. Dr. Fotopoulou, thank you for accepting our invitation for today. We know that you are on vacation, and we thank you for taking your time to share with us your experience in this very interesting area of the gynecologic oncology field.
Thank you very much for the invitation. I'm very honored and privileged to be talking to the gynecology community in Mexico. I've never been there, and I hope I can come in person one day. But now
we hope you can come because of this pandemic. It was not possible, but
I know it's amazing. It's amazing. We connect with people all over the world with webinars. It's very interesting times. Anyway, so I'm going to talk today in the next minutes about why screening has failed in ovarian cancer. A very small background. You all know that epithelial ovarian cancer, even though it's a rare disease, and it's the fifth leading cause of cancer in women, it's actually the highest reason and the most common reason of death from gynecological malignancies. The problem is that more than 70% of patients will be diagnosed initially in stage 3 or 4 disease. So we have no way of diagnosing it in early stages. And these are relatively young women, around 60, 65, and we are being confronted with abdomens full of disease, full of peritoneal carcinosis, diffuse symptoms, inoperable cases. And the question is, how can we, with screening, prevent having such late cases, and how can we diagnose the disease earlier and improve outcome? So the fact that ovarian cancer has failed to be diagnosed early so far is being projected in many terms and in many terminologies that have been given to this disease over the years. It has been called, it's a silent killer. That's what patients know. People say that ovarian cancer is actually not really ovarian cancer. It's just a confluence of many diseases, and we're going to explain later why. And we as gynecology community and as specialists have had as a task and aim over the last decades to try to establish a screening program like we have for smear tests for cervical cancer as a holy grail in order to try to make this disease less killing, less silent, and more obviously apparent in early stages. So what were our aims? Let's start with the aims in order to see why we failed at those aims. Our aim were to detect precancerous lesions so that once we treat them, they will not progress to cancer, like, for example, in the example of the smear test. We wanted to stage the shift of, instead of having 80% of patients being diagnosed in stage 3 and 4, to have them being diagnosed in stage 1 or 2, both in low risk and high risk population, so that these patients can be treated easily and with higher survival and cure rates. And of course, the utmost outcome would be to improve tumor-specific and also overall survival rates just by increasing the probability of the disease through diagnosing it in lower volume disease, and also by having a smaller tumor, lower volume tumors, to increase potentially the response to systemic treatments. This was the holy grail of the gynecology community. This was the dream of why we started the screening. So this is a table that summarizes the most important screening studies in ovarian cancer. It's one American study, one Japanese study, one American study that was not just specific for ovarian cancer, but also for lung, colorectal, and prostate. And of course, the probably most common to us in Europe is the UK TOC study, which is the United Kingdom collaborative trial of ovarian cancer screening, which we in the UK completed only a few years ago, and we're still waiting for final results. So the completely homogeneous outcome of all these trials was that there is absolutely no survival benefit of screening modalities in ovarian cancer at all. And the question is, why have we failed again and again and again in this disease? These are the curves. Before we go further, you see that it's not that we just failed, it's just that the curves were completely the same in the screening, in the more intensive screening arm versus the control arm. And the same was in the UK TOC study for the first 12 years. However, we see that there is an opening of the curves after a decade or 1.5 decades. And we still do not have the final results of this year. However, so far, after 14 years, there is absolutely, again, no evidence, no difference of anything. In the PLCO study, the American study, it was a US population. It was almost 80,000 women. They had a simultaneous screening with CA125 and transvaginal ultrasound compared to just standard of care, just going to your GP and saying how you are. And this did absolutely not reduce ovarian cancer mortality. And the UK TOC study, the primary output was ovarian cancer death by end of 2014. The problem with that study was that it included both epithelial but also non-epithelial ovarian cancer. And as you all know, germ cells and sex-cord stromal tumors are completely different disease than the epithelial ovarian cancer. It unfortunately included borderline epithelial tumors. We now know that borderline epithelial ovarian tumors are not cancerous. They are a complete separate tumor entity. And what the problem in those studies was that it did not include primary peritoneal cancer. We nowadays know, and I'm going to explain it a bit later, ovarian cancer is practically the same with primary peritoneal, the same with fallopian tube cancer. So this study was almost designed to flow just by the definition of the inclusion criteria and also how they defined ovarian cancer. So what those studies, and especially the UK TOC study, showed us is that not just screening failed in terms of it didn't improve survival, but it also showed harm through the screening, through the incidence of false positive results. So if you see here the statistics and the findings, approximately 1% of the patients who were screened underwent surgery just because of abnormal findings. The surgery in the intensive screening group was much higher, significantly higher than in the control arm. Most cases were done per laparotomy. It was an earlier study, an older study, so laparoscopy was not as handy as it was now. Almost 90% of patients were operated in vain, so for no reason, because of either no pathology or just benign pathology. And unfortunately, 3% of patients had actually a surgical complication like an organ injury or hemorrhage or trocar complications. So you have women who actually were harmed through the intensive screening because they were operated for no reason. And they were operated, whereas they wouldn't be operated outside of the study or outside of the intensive screening. And unfortunately, those who were operated for no reason, 3% of those had a complication. And even though 3% is actually not in absolute numbers very high, still 3% in benign pathology or in no pathology is actually not negligible. Therefore, there were significant critique points for the UK TOCs. Overall, the study, if you take it as it is, there was absolutely no reduction in mortality. However, if the authors, when the authors removed the prevalent cases, as you know, prevalent cases are all the cases with ovarian cancer that were already present during the study, so did not develop during the follow-up, but the patients had it even before enrollment and they just didn't know. When they were excluded, there was actually a reduction in mortality, and the question is, why was that the case? The second very important critique point is why a late effect. If you remember the curves that I showed you, they were completely the same till year 12, 13, and they started to go divergent after year 14. Why is it so late? We all know, and all of you who treat ovarian cancer patients know, that 80% of our patients will die in the first 5 years or relapse in the first 5 years. So why do we have such a late shift of mortality changes after almost 2 decades? It's actually something that we can't really explain. There was just a trend towards earlier stage detection, just a trend. So at the end, despite our more intensive screening, the patients were failed to be diagnosed in earlier disease. And the very, very important point was that there was absolutely no predefined management plan in patients that had a positive screening. What do I mean by that? Patients who had a positive screening and patients who were alarmed as being positive, instead of having an algorithm of what should be done with them, the only suggestion of the study was that they had to be referred to a gynae cancer center. What this gynae cancer center did with those patients were completely up to that center. So it meant that some patients were alarmed to be positive. However, the local gynae cancer center said, listen, the patient is asymptomatic. I don't really see anything. I'm not going to operate the patient just because of a CA1 to 5 and because of a screening trial, and just continue observing it. So there was absolutely no predefined treatment or management of the screening positive patients. The second very important point was that those who were operated because of a positive screening is that the quality of the surgery, especially 20 years ago where the study happened, was not of very high quality. What do I mean by that? First of all, it was not defined that only gynecological surgeons and high volume surgeons should operate those patients. There were many of the patients who I have seen that took part in the UK TOC study that had a surgery only by Pfannenstiel. So it was it an adequate staging? Was it an adequate exploration? We all know nowadays that patients with ovarian cancer should have, if they don't have a diagnostic laparoscopy, they should have a midline incision to be able to explore the whole abdomen. There were many patients where after a very small cut from the surgeon, they said there was absolutely no residual disease in the inspected field, but the diaphragm, the upper omentum, the lesser sac, they were absolutely not inspected. And all this is because in the UK, it is generally a very restrictive and very conservative surgical philosophy, where unblocked resection and large radical resections are rather criticized, and also by NICE, which is the National Institute of Health and Clinical Excellence that defines management in NHS, says that these radical procedures need to be undertaken with care and etc. So it was very tricky to see a survival benefit in patients that had ovarian cancer. However, they were not operated in high quality. And as we all know, in ovarian cancer, if we don't operate in high quality, then this surgery has absolutely no benefit and no effect. So these were all problems, and therefore, and that was also by the authors themselves criticized during the presentation of the study in ASCO and also in all the centers. How does it look like in patients with family history? So as we had the UK TOC study, we had the UK FOX study. This was exactly the same study, just in patients with family history of positive BRCA mutations. The results here, they were, even though they were more encouraging than in the standard population, in the non-high-risk population, still the screening was not as effective, as safe to be considered an alternative to prophylactic salpingoforectomy. Adam Rosenthal, who himself presented this study in ASCO, I remember him saying that many of the patients who had been operated in the screening arm that was found something positive, they actually had residual disease in the diaphragm just because of inability of the surgeons to reduce or to remove the disease in the diaphragm. And this is something that nowadays, if this study would happen nowadays with the surgical quality that we have in the centers nowadays, would have never been the case, just because we know how to explore the diaphragm, how to dissect the liver, and how to do safe resections in that area. So even the screening in high-risk population, with all the limitations of the study, did not result in reduced mortality. And of course, the very, very important critique points of all the screening was that there was a significant psychological impact. Many of the patients who had false positive results, they were associated, as one would expect, with increased distress in the short term. However, interestingly enough, like with all quality of life studies in ovarian cancer, many of the women actually they were happier to take on themselves a bit of higher complications or even a surgery in vain, just to be sure that they don't have or they will not develop ovarian cancer. So one could say, okay, the screening studies have failed, then we should just tick the box and say whatever, this will should never be pursued again, and we should just forget it. It's actually not as easy as that. What the UK TOC study has taught us and has actually demonstrated is that even though screening just in black and white parameters failed, what it taught us is that the concept of serial tumor marker measurements might actually be beneficial. What do I mean by that? There was the ROCA algorithm. I don't know if you know it. It's an algorithm according to which you don't just take the CA1 to 5 as it is as an absolute number. 20 is normal, 36 is abnormal, but to show how the CA1 to 5 increases over time. So what the UK TOC study showed is that if you use the screening by using the ROCA algorithm, it actually doubled the number of screen-detected epithelial ovarian cancers compared with just a fixed cutoff. What do I want to say with that? This is a patient, for example, for you to see in the UK TOC study. It was a BRCA1 carrier. She was 64 years old at the date of diagnosis, and it was a patient that was diagnosed with a fallopian tube cancer stage 1C. So this patient was being followed up from 2004 till 2010, so for 6 years. This patient had always a tumor marker of 10, 11, 12, 13, 10, 11. And then suddenly, 4 years after inclusion into the study, she started having a tumor marker above its personal cutoff. So she had a tumor marker of 16. Then it fell a bit, and then the tumor marker went to 18, then to 19, then to 25, and then to a bit less than 30. So even though per definition this patient never had an elevated tumor marker or an abnormal tumor marker according to the cutoff of 35, still for her own cutoff, which was around 11, she had an elevated tumor marker. And the team in the UK TOC study got sensitized by that through this ROCA algorithm and flagged her as screen positive. And indeed, this patient was diagnosed to have a very early fallopian tube cancer. What does this mean? It means that if we indeed do not just take the C1 to 5 as an absolute cutoff, but as a dynamic value over time and use the personal cutoff of the patient, that actually might be beneficial. So I have, before I gave this talk today, I have contacted my friends and colleagues who did the UK TOC study and asked them when will we have the final results. And they always say in a few months. Now, especially with the corona pandemic, the results will be probably out either late 2021 or early 2022. They absolutely have no idea of the final results yet. And they themselves say that this is the $100 million question. I hope that in ASCO next year, we will have the results, whether on a long term of 2 decades, the screening in ovarian cancer might have a positive outcome, especially if you use the ROCA algorithm. So why do we keep failing? Why is it the case? Let's start from the beginning. We said that we want the screening of ovarian cancer to be something similar like the smear test. So we want to have the CAN1 that goes to CAN2 and then that goes to CAN3, and we do a cone excision here and then we never have cancer. That is the easy concept and the great concept. And our idea was to have, in an ideal world, a cystadenoma that is diagnosed as a cyst that is perhaps suspicious, and we take out the cyst through a small laparoscopy, and this cyst will not develop to ovarian cancer, either a borderline as a pre-stage or a low-grade or high-grade ovarian cancer. This is a complete illusion, and this is unfortunately not the case. And the reason is that ovarian or high-grade early ovarian cancer, we are not really sure it exists. And we're going to talk why, but stage 1 high-grade serous ovarian cancer is probably an illusion. It's probably just a result of an incomplete staging. And the question is whether we should, instead of trying to concentrate on diagnosing earlier stages, to just concentrate on detecting earlier tumor volume, so lower tumor volume. You all know how the pathophysiology of ovarian, pathogenesis of ovarian cancer is. We assume and we think now that everything comes from sticks in the fallopian tubes that are precancerous, in the state of precancerous over decades. Nobody really knows how long. And with the mutating, mutagenic impact of the follicular fluid, of other environmental factors, etc., it over the years develops to cancer. And because of the ovary is actually the first stop of these cells, we thought initially it's ovarian cancer, but actually in the reality, fallopian tube cancer. And you all know that these sticks, these little cells, they disseminate. I try to explain that to my patients like a trumpet where you blow air through the whole room. It's the same with the fallopian tube that blows these cells through the whole peritoneal cavity. So to diagnose an early fallopian tube cancer would mean that you have to really catch those cells in their transition from sticks to invasive cancer that are still only in the fimbrial end. And that indeed is extremely, extremely difficult. You all know stories like that. You all know pictures like that. You see patients with completely normal ovaries, but with peritoneal disease everywhere. You see here small nodule carcinosis. I don't know if you can see it very well from my laptop, but very small nodule carcinosis with completely normal ovaries. And here the mesentery. These are just the cells that have been disseminated through the fallopian tube throughout the entire peritoneal cavity, despite the fact that if you actually look through the transvaginal ultrasound in the ovary is fine and it's normal. And again, pictures like that, the illusion of an earlier stage. This is a stage 3C, this is a stage 3C, both inoperable, impossible to clean the whole mesentery from this disease here. Yeah. So the question is, that the problem is that these screening methods or these screening programs and studies not just included the wrong patients. So they included borderline patients, which are not really cancer. They excluded peritoneal cancer, which is actually ovarian cancer. So not only they made this mistake, but also they wanted to just black and white have early stage versus lower stage, which probably is a mistake. What they should have done is that they should have compared earlier lower volume versus higher volume disease, even if this is stage 3A versus 3B versus 3C, or even lower volume 3C. It's different to diagnose a patient with just an omental mass, which makes a 3C, compared to having diffuse disease in the lesser saccant in the stomach. And another problem in the UK TOC study was the incomplete staging. Coming back again to the phanencil incisions, it was impossible for those patients to be completely staged and have a good omental biopsy from the supracolic omentum, diaphragmatic biopsies, peritoneal biopsies from the upper abdomen. We know that by doing all this in apparently early ovarian cancer, approximately 30% of the patients will be upstaged to a higher volume disease and a higher stage disease. And this was actually failed to happen, especially in the UK TOC study. And if we want to make it even more an illusion, is that if this is a very nice mathematical model published in PLOS Medicine a few years ago, trying to depict the preclinical natural history of serous ovarian cancer and how can we, per screening, detect those lesions. In order to actually detect them, we have to know that cancers, high-grade serous ovarian cancer, is theoretically spending on average more than 4 years in situ, so like sticks, goes then to stage 1 or stage 2, and approximately after a year, it goes to stage 3 before it becomes clinically apparent. Yeah, so we have approximately a journey of 5 years before we have a clinically symptomatic patient who walks through the door as we know her with ascites and inability to breathe or going to the toilet. For most of this occult period, most of the lesions are less than 1 centimeter. And I'm asking you, how is it possible, any screening method, to be able to diagnose something smaller than 1 centimeter inside the abdomen? It's very, very tricky. So in order to achieve a 50% reduction in ovarian cancer mortality within any annual screening, we would need to actually define and establish a test that would detect tumors less than 0.5 centimeters in diameter. So that is very, very tricky, and especially in a disease that is not just in a cavity, like in colonoscopy, like colon cancer, or like CIN in cervical cancer. It's distributed through the entire abdominal cavity, which is endless, and you would have theoretically to laparoscope those patients every year, which of course would be impossible. For that reason, we have, and many of the working groups and scientific groups worldwide, try to think outside of the box and say, okay, since screening is failing, but screening in the traditional model of doing an ultrasound or doing a CA1 to 5, why don't we just try to think outside of the box and do something else instead of the traditional screening? So what they did is to try to take the uterine lavage, so take the fluid that was collected from the endometrial cavity, in the assumption that all the little cells, the sticks that were producing the cancerous cells in the fallopian tubes, they were excreting cancerous or malignant cells through the uterus that could be then collected into a lavage from the uterus. So Robert Zeilinger from Vienna, a good friend and colleague, together with Paul Speiser, actually published that in GCO 5 years ago, and showed that actually in patients with ovarian cancer, in even earlier stage ovarian cancer, when you do uterine lavage, you can actually gain sufficient amounts of DNA in almost all patients. And you could see that there were malignant cells in the fluid that you could gain from the uterus. So this study proved that actually tumor cells from ovarian neoplasms are actually shed into the uterus and can be collected via lavage in the uterine cavity. Yeah. Still, this is a rather invasive tool where the patient would need to go to the anesthetic room. Yes, we could do it without anesthetic, but still it would be a bit more tricky than just a smear test, and it's something that has not been established so far. So some other colleagues tried to do something less invasive, and they took tampons of patients with high-grade serous ovarian cancer. So they took tampons, like the normal tampons we would know. They put them into the vagina, and then they collected them after some hours, some days, depending on the study cutoff. And they actually took the tampon and they saw whether there were any malignant cells. So this is a very nice study published a few years ago. 33 patients, 8 of them had advanced ovarian cancer. And actually they could identify p53 mutations in all tampon specimens of all 8 tumor samples. So these are promising results. These are nice results, however, still far away from any clinical reality. But any new grants that I've been seeing and any new efforts that I've been seeing currently now towards ovarian cancer screening is in that direction of trying to gain some secretion from the uterine cavity. If you go and you do online in the clinical trial site, any studies of screening in ovarian cancer, this is something that I did yesterday. It's 34 studies that you see. Most of them are terminated, some are still recruiting, and most of them, as you see, they're using gynecological fluids or mucus or uterine lavage, so they have gone outside of the box of the traditional screening in ovarian cancer. So before I end, I would like to show you some upcoming and new approaches to screening, even more new than what I have discussed with you with the uterine lavage. We're doing this in Imperial, in Imperial College in London. This is a very, very nice approach by my colleague James Flanagan. It's actually, I find it geniusly. It is a study that tries to use loyalty cards. I don't know if you have in Mexico loyalty cards, but here in the UK, if you are registered to your local pharmacy, for example, Boots, we have in the UK Boots, you can have loyalty cards so that you get a discount every time you buy something. So they wanted, and then it registers, this loyalty card shows what drugs or agents this specific individual bought over time, over months, over years. So what this study wants to see is whether patients with ovarian cancer that is still not detected had a change in the purchase of the things that they bought because of the symptoms that they didn't know yet that it was ovarian cancer. For example, you know that ovarian cancer can cause sometimes constipation and can cause acidity. So we wanted to see whether patients who had clinically undetected ovarian cancer started buying with their loyalty card more drugs against reflux, more laxatives, and to see whether there were significant changes in the purchase behaviors over years that would signalize the development of ovarian cancer at some point in the future. It's a very interesting approach. It's something that we have now started only a few months ago in the UK. Eligible participants will be any woman in the UK who has at least one loyalty card. And we have collaboration with just high street retailers, so just people who just sell in pharmacies those type of drugs, and they will then report to us completely anonymously whether the behavioral the purchase behavior of specific individual changed, and then whether this individual at some point developed cancer and in what stage. So the estimated enrollment is approximately 1,000 participants. We want to, we have started last year, and we want to recruit for approximately 2.5-3 years. We have to say that now through the pandemic, there will be a gap in the study, but at the end, we want to see whether retrospectively in these 1,000 participants, any behavioral change correlated with the development of ovarian cancer. And then we have the clock study. The clock study is, this is the clock study, sorry. Primary outcome, we said here, purchase behaviors, and then secondary outcome measures is alert about cancer symptoms. So for example, we want to see if they had a purchase, if they had a behavioral change, in what terms, in what regards this was. Was it that they bought higher laxative? Was it that they had more reflux medication? Was it that they had more diuretics? What was it? What was the signature? And what was the alarm and the alert that would signalize ovarian cancer in the future? This is a very interesting study. And then the second study is a progress trial where we do it in Imperial. I personally also have participated in that. It's a very interesting personalized genetic risk estimation of cancer screening and prevention. So what this study does is actually that it takes saliva and DNA and tries to make a polygenic risk score in combination with some epidemiological data, family history, and tries to establish an algorithm, a high or low risk algorithm for each patient, and then to put them into a high or low risk category that will then say, okay, if I have a patient with a high risk category or a high risk signature, instead of starting the mammogram, for example, this is also combined with breast cancer at the age of 50, like it is in the UK, to start it early at the age of 40 and to see whether this changes the outcome of breast and ovarian cancer survival. Also an interesting study, however, like with all such studies, we will need many years till we have any outcome. This is here the plot of the study. It will be approximately 500 patients between 30 and 60 that attend their GPs. The good thing with the UK is that all patients are registered to general practitioners, so we have access to them and we can ask them whether they want to participate. We will start with 5,000 patients, but then only 500 will have a really genotyping of the saliva and calculating of their genetic risk, and we will review them every 6 months. And then we'll see what the impact of this modified, more intensive monitoring will be on these patients. The expected outcomes will be that it will be the first study to evaluate behavioral effects of population and how to combine genetic screening, genetic signatures with epidemiological factors. And at the end, we want to provide pilot data for future studies, for not just screening just forever, to do an individualized screening according to your family history, according to your personal genetic risk, and also to your behavioral patterns. I think it's a bit too much. So in summarizing, even though there is absolutely no evidence of cancer-related mortality reduction through screening, still the screening studies so far have taught us some things. They have taught us that the concept of absolute tumor marker is probably completely gone, and we shouldn't really use it. We should use the serial measurements of increase compared to an individual cutoff. We should not concentrate just in diagnosing earlier stages, but rather lower volume disease. If I have a lower volume disease, I can treat this patient easier. She will be more open, and she won't be as sick as high volume peritoneal carcinosis everywhere. And what I can only say is that we can't and we shouldn't just give up saying this is just a useless effort and useless anything we do is useless in ovarian cancer and all our patients will just die. That's absolutely not the case. We have, as a society and as a gynecology community, have developed new upcoming, very promising strategies to actually personalize a screening service so that in the future we have much less futile results. Thank you very much.
Now we have some time for discussion. I have one question from the audience, and they are asking, in breast cancer, we take around 1,000 mammograms to find one case of breast cancer. That more efforts are needed to be done to find a relatively effective way to make early detection in ovarian cancer. What would be your opinion on this respect?
So the problem is that breast cancer affects 1 in 8 women or 1 in 10 women, yeah, and ovarian cancer affects 1 in 70 women. So it is a much more rare disease. Yeah, it's a disease of a bit older patients. So any benefit of any screening would mean that we have to screen many women to be able to prevent one death. That is true. And for that reason, we need a non-invasive test. And we need a test that will not harm. So, for example, the 3% surgical complication rates from unnecessary surgeries is already very high. Yeah, and we cannot afford it as a community, and especially in systems that are not very rich. And against perhaps some beliefs, the NHS is not a rich system. Yeah, and that is why. So it is very difficult to put it in numbers. However, what needs to be done is it needs to be a non-invasive test with low complications of the false positive. Yeah, because for example, in the mammograph, if you have a false positive mammogram, you just do a biopsy. What is the harm of that? Yeah. But if you do a laparoscopy and then you injure the bowel for a benign disease, that's actually not allowed. So it will be very tricky to find something that is not effective, but also not harming the patients. Yeah, or not the patient, not harming women. Yeah, that is why the approach towards a personalized screening according to the genotype, according to the genetics of each patient, according to the family history, according to the behavioral patterns is actually more preferable.
Yeah, and you mentioned that like a personalized level of CA-125.
Yeah.
How can I do in my everyday clinic to say, okay, this is the cutoff for this specific patient, and this is the cutoff for this other patient.
Yeah.
I mean, because this seems to be very easy to be done.
I know.
Can be reproducible, probably.
Yeah. So it depends. Yes, it can. It depends on the health system. For example, I am Greek. Yeah, in Greece, almost all patients that will go to German, yeah, in Greece and in Germany, patients will go to their normal gynecologist and outpatient gynecologist. They will see a little cyst and they will do a tumor marker. That's the standard, what everybody does. And then you see a cyst, you see a tumor, you have a tumor marker that is 10. The gynecologist will say to the patient, that's probably nothing, come next year. Next year, they will do the same. So they will have the record of these tumor markers. In the UK, where there are no outpatient gynecologists, there are only the GPs, and it's expensive to do CA125, so very little GPs will do it. You actually will not have serial CA125. So it depends on the system. Yeah, I have patients here in the UK where the patients, they come to me with, they say to me, I have had a cyst since 5 years. Yeah, and it has been going up and down, but nobody did anything because they said it was benign. And then I said, and how's your tumor marker? And most of the patients, they will not have a tumor marker. In Germany or in Greece, they will. It depends on the system, just because the philosophy is different. And what I then will see is that if I have a patient with a cyst that is there since, 3 years, then now it starts increasing. 3 years ago, the tumor marker was 6, and now it is 34 in an increasing mass. Even though it's small in a postmenopausal patient, I will have a low threshold to do a laparoscopy, then have a look.
Yeah, because we have to keep in mind that in early disease, almost 50% of patients will have a normal CA125.
Exactly. That is the point. Exactly, that's the point. On the other hand, an advanced, yeah, exactly that. Yeah, so it's all about the increase in the personal cutoff. Mm-hmm.
Yes. One other question is, nevertheless, transvaginal ultrasound is feasible and economic. Might be one option to be done every year. Could it be?
Listen, in a complete non-evidence way, I would say yes. But you say in Mexico it is cheap. In the UK, you have no access to transvaginal ultrasound because the patients, they do not have outpatient gynecologists.
Right.
They only have GPs. The GPs are general practitioners. They do not know how to do a transvaginal ultrasound. This means in order for a patient to be referred for a transvaginal ultrasound, the GP has to pay, the patients have to pay, so it's not easy and it's not cheap. If you have a system like the Greece or perhaps in Mexico or like in Germany, where every gynecologist will see the patient once a year, and they just have the ultrasound machine next to the smear test, and they just put the probe and have a look, yes, that's cheap and easy. But unfortunately, not all the systems support that.
Yeah, of course.
Yeah, that is a problem.
But
and on the other hand, you also have the wrong reassurance. Yeah, I showed you pictures from surgical specimens with normal ovaries. So there are patients with bloating, yeah, with peritoneal disease, small volume, where the gynecologist will do an ultrasound, transvaginal, not a specialized gynecologist, but just a general gynecologist will see the ovaries and they will say, the ovaries are fine, there's nothing wrong with you, come in a year. And the patient will have low volume ovarian cancer. So there are both problems in both sides.
Yeah, but if you have, what would be less expensive, this approach with ultrasounds or the genetic testings, which in most countries is much more expensive?
I understand. I would go for the transvaginal ultrasound, but again, it depends the access to this transvaginal ultrasound. If I have a normal UK or Irish patient, she has no access to transvaginal ultrasound, just because the GP does not know how to do it. And the moment you refer her to a gynecologist, it's already a referral. It's already expensive for the system. So I don't know how it is in Mexico, but indeed, if in Mexico you have gynecologists who can scan, then yes, that's the easiest way to just do a scan. I agree with that.
Yes, it's the same here. Probably the same. We have much more access to an ultrasound rather than genetic testings.
Okay, then it's the easiest. It doesn't harm. It doesn't harm to do a transvaginal ultrasound. It doesn't harm.
Even though there is no strong evidence for using it.
Exactly that, but it's of no harm.
It will be the end point to have low volume instead of early disease.
Exactly. But you need to be careful. Patients who have still persistent symptoms of ovarian cancer, despite the fact that they have a normal ultrasound, yeah, of the ovaries, we should still pursue it and try to investigate further. Not to say, oh, the transvaginal ultrasound was fine, you don't have ovarian cancer. That is also not the case.
But then you have to combine the ultrasound with the CA125 and other tumor markers, probably.
Exactly that.
Okay,
so it needs to be done by somebody who knows what they're doing.
Yeah, the most important thing is to individualize every case.
Exactly.
And to see what the patient is having during the time and what she is having during every study and between the studies.
I completely agree with you, David.
Is that correct?
I completely agree with you, and that is the future. The future is to individualize the approach and the screening service. Exactly that.
One thing that is very interesting for me is that you mentioned that during the time of the UK talks, the quality of surgery and the decision of the physicians were very important points in the results. It happened a few years ago, you said 20 years ago, but how is now this quality of surgeries and the decision of the physicians after all these results that you have?
Well, you know the Chorus study. The Chorus study was presented by Sean Kehoe a few years ago only. It showed that how many patients were operated tumor-free upfront? 10% only, something very small. Yeah. So that reflects the quality of surgery of a few years ago. I have to say that now the quality of surgery in the UK increases. The acceptability of NICE is the National Institute of Clinical Excellence, increases for radical surgery. And what I think the future will be, it doesn't have anything to do with screening, but just in discussion, is that there will be in the UK they call them ultra-radical centers. So they have gynae-oncology centers, but not every gynae-oncology center can strip the diaphragm. So that they have a centralization of centralization. So to have centralization of gynae cancer centers that will be able to do this ultra-radical surgery. Yeah. Okay. That is probably the future. How is it in Mexico?
It's very complicated because we have several systems, and probably our institution is one of these centralized institution, probably. One other question from the audience is, what do you think of the liquid biopsy taken in the serum?
Yeah. That is something that I left completely out. We are now within ESGO, the European Society of Gynae-Oncology. We are now preparing a consensus statement, something like guidelines within the guidelines committee of ESGO, of detection of ovarian and characterization of ovarian masses, and liquid biopsy will be a significant topic. And we have done a lot of literature research on that. Unfortunately, the liquid biopsy in the as a piece of the puzzle in the diagnosis of undetermined masses is far away from established yet. Yeah. If you have a very advanced ovarian cancer and the patient has positive DNA or circulating tumor cells, yes, that will be the case. The problem is in a very early stage 1C, this patient will probably not have positive liquid biopsy, will it? And as we know, the circulating tumor cells for ovarian cancer are much more difficult to detect than in other cancers.
Why is that?
We don't really
Why do you
know.
consider that?
I don't really know, and I haven't really done a lot of work in that area. However, I have talked to Robert Zeilinger, who is from Vienna, who are doing this type of work. It's much more an illusion and much more elusive to do that than, for example, for breast cancer. Yeah? So it is tricky, and it's also not cheap.
Absolutely.
It is also not cheap. Of course, and very interesting approaches, this Harmony and Panorama test that we do, the pre-invasive diagnostic for the pregnant women, where we see and I'm sure you know that there were some women where it was cancer cells diagnosed instead of just the baby cells. So the technology is there, and I think in the future, when the technology which will be much more refined and cheaper, we can establish it in, it is a very promising method, but I think we are far away from that yet. Not I think, it is unfortunately the case, we are far away from that yet.
Yeah, and to end our session for today, what would be your last take-home message for our residents and for our young fellows that are in this field?
Yeah, it is to never give up. So even though screening, as one sentence, it has failed. Yes, it has failed in a traditional way. Still, however, we are screening in a much more thinking out of the box way, with circulating tumor cells, uterine lavage, with many other things. I think it will at some point bring some results. The concept of serial tumor markers is very important, like we do with follow-up of ovarian cancer. Yeah, if you have a follow-up patient with ovarian cancer, you already are alarmed if you have a tumor marker jump from 6 to 30. It's the same with the initial diagnosis. Yeah.
Okay.
And at the end is to individualize like we individualize surgical and systemic care, to do the same with screening.
Absolutely, absolutely. Well, Christina, we thank you. We thank you for sharing your experience with this topic, and thank you for taking your vacation time for us.
No, it's my pleasure. It was my honor and pleasure.
And I hope we can have you here in the next few years in Mexico, in our
in your beautiful city. I hope too. I will very much be very happy to accept such an invitation. Thank you very much, David, and everybody.
Thank you, and enjoy your vacation. Thank you very much. Muchísimas gracias a todos. Muchísimas gracias a toda nuestra audiencia. Ha sido una experiencia muy interesante, mucha información acerca del tamizaje en cáncer del ovario. Ya vimos que no es posible tener un buen método para esta neoplasia, y lo más importante, individualizar los casos, ver el seguimiento de estas pacientes. Es posible tener un CA125 en forma seriada, aún en que los pacientes no tengan una neoplasia maligna, y lo más importante tal vez será identificar a aquellas mujeres que tienen enfermedad de bajo volumen y no tanto una enfermedad en etapa temprana. Muchísimas gracias y nos vemos por aquí pronto. Quédense en casa los que puedan quedarse, lávense las manos, usen su cubrebocas y cuídense mucho y cuiden a sus familias. Muchísimas gracias a todos.
Thank you. Bye.
Bye bye.